Instead of focusing on winning arguments, we're teaching the basic fundamentals of sales and marketing and how we can use them to win in the world of politics, teaching you how to meet people where they're at on the issues they care about. Welcome to the Brian Nichols Show. Well, hey there, folks. Brian Nichols here on another fun-filled episode, yes, of the Brian Nichols Show. I am, as always, your humble host, joining you from our lovely Cardio Miracle Studios here in sunny Eastern Indiana. The Brian Nichols Show is powered by the best heart health supplement in the world, Cardio Miracle. So if you want to learn how to lower your resting heart rate, lower your blood pressure while improving your pump at the gym, stick around. We're going to talk about that more later in today's episode. But first, will curbing competition help lower drug prices? That is the question of an article we're answering today. And to join us to discuss all that and more is from the Mercatus Center, Satya Marar. Satya, welcome to the show. How you doing?
Hey, good. How are you going?
Doing quite well, man. It's a Monday. Can't complain there. We had a nice July 4th weekend. Got to go to the beach. I hate sand, so that was fun. But beyond that, it was a good July 4th holiday. How about you?
Yeah, it's been great. Great 4th of July. You know, just wish it wasn't so damn humid here in Virginia. But besides that, can't complain. You know.
There you go, bud. There you go. Amen. Well, let's go ahead before we dig into today's episode, which we're discussing. Will curbing competition lower drug prices? We're talking about what's been taking place. I think it's Arkansas is where Sarah Huckabee is the governor. Keep me honest here, Satya, right? She's been going to war with all these PBMs, these pharmaceutical benefit managers, I believe, talking about how we can go ahead and buy pharmaceuticals en masse, in bulk, and then help lower the prices, give some rebates to pharmacies, and all that and more. But before we dig into that, do us a favor, just introduce yourself here to the Brian Nichols Show audience, and what's your history here in this whole pharmaceutical policy conversation?
Yeah, so I'm Satya Marar. I'm a postgraduate research fellow at the Mercatus Center at George Mason University. We're a think tank, and I'm mainly involved in researching and writing on competition issues in various industries. And, obviously competition is an issue in every industry, but healthcare, one of the most heavily regulated and often concentrated, and the two go hand in hand because, big businesses find it easier to bear the massive costs that restrict the entry of smaller players. Healthcare is incredibly expensive. It's a huge part of the federal budget, and 9% of that line item happens to be purchasing drugs on behalf of the public insurers like Medicare and Medicaid. And then, of course, we all pay significantly higher prices in the US for the same drugs that other countries get for cheaper through our private health insurance plans. And there's many different reasons for that. But what's going on right now is, drug makers, Big Pharma is under the spotlight for high drug prices. People frustrated about that. And they've kind of resorted to blaming PBMs, who are basically the entities that negotiate drug buys on behalf of private insurance plans. What they do is they pool together patients across many different plans. They use a bulk buying power to negotiate discounts or rebates and lower prices, which are then passed on to the health plan clients. So, as a starter, we should always be skeptical when the folks who are tasked with negotiating lower prices with the folks who end up losing out on their bottom line because of that, when that second category of folks blames the first category, we should be a little bit skeptical, I think.
Yeah. Well, an elephant in the room. Healthcare is, to your point, one of the most regulated industries in the United States of America. And I guess, the main crux of the arguments I've heard about, going after PBMs, and the goal, right? We always talk about solutions here at the show is to help lower pharmaceutical prices, lower those drug prices, right? So this is what I hear from a lot of folks out there, Satya. Keep me honest here, right? Here are the top 10 objections I hear. Well, first, we're talking about rebates, right? But rebates are going to push up the overall sticker price because to win bigger rebates, drug companies are going to hike up the official list price, meaning uninsured or high deductible patients are going to get hit with higher bills. So that's one thing I've heard. Another is that patients don't get to see the price that PBMs are getting, right? Those big rebates usually go to insurers or the PBMs themselves, not the patients who are paying at the counter. So real savings never really reaches them. That's what I've heard there. How about that? Let's just start with these first two of the objections I've heard. What's your feedback there?
Yeah, so rebates are often, but not always, a percentage of the drug's list price. And there's often a huge difference between the list price, which is officially advertised by the pharma company, and the net price that the insurance plans actually pay. So what happens is, even if the price goes up and results in a bigger rebate, those are still cost savings that are passed on to the plans, which then get passed on to the plan customers. And if you were not, if employers aren't happy with their plans, they can switch to a different one. And in many cases, they choose to do that. But based on the surveys I've seen, 9 out of 10 are happy with the plans that they have. And PBMs were found to, in general, pass on well above 90% of their rebates ended up being passed on to the insurance plans themselves, which means lower premiums. And also, look, even if there's an expensive drug for a particular condition, it might be a condition that applies to very few people. And then to list that drug on the formulary of the insurance plan, even if it's a more expensive drug, those rebates are still offsetting coverage costs for everyone across the plan, which might include drugs that people more typically use. Look, everything that goes up, has an effect somewhere else down the track. So you might say, well, people uninsured may not benefit from these specific discounts. Well, the problem is, think of the millions and millions and millions of people who are on these plans, including Medicare and Medicaid, which enlist their own PBMs. The Congressional Budget Office found in 2019 that if you forced the PBMs that represent Medicare and Medicaid plans to pass on those savings directly to the patient at the counter rather than to the plans themselves, taxpayers would end up paying $7 to $10 billion more than we pay to fund these programs. They're already very expensive.
Why is that? Like, what specifically, like the economic behind the scenes that would make that reality?
Yeah, so I mean, it's a difference between passing savings on to the plan itself, which allows them to spread out their costs across everyone being covered, versus passing it to the individual patient, right? So a patient might say, well, if my plan covers the specific drug, which is expensive, and I can get it for free, that's great. So they will end up spending more on their own healthcare if the plan is covering it. Whereas if the savings are passed to the plan itself, that is spread out for everyone who's on the plan. So one
really quick to the spread pricing. So this actually goes right into another objection, which is why I wanted to bring this up as you were saying that, right? So one of the objections I heard was that PBMs often charge insurers more than they pay pharmacies and pocket the difference. So in 2021, PBMs captured 40% of Medicare Part D generic drug costs, while the actual drug makers, according to the NCBI, only got 30%. And then with that, the FTC found that 3 of those big PBMs marked up certain generic drugs by over 1,000%, which ended up in the process lining their pockets, not necessarily helping patients. So what would you say to that?
So this is another misconception. So spread pricing does happen, but there are tons of PBMs that offer the opposite model, which does not include spread pricing. What spread pricing does is it provides certainty, right? So if it's sort of like almost like a futures contract. What it says is, well, if the price of this drug ends up going up, then we're kind of insulated from that. We know ahead of time, we have some certainty on how much this drug is going to cost us. Conversely, the price goes down, then, well, the PBM ends up winning the futures, basically the bet. And plans will opt for this sometimes because they want that certainty. They want to know ahead of time how much it's going to cost us. And look, one of the things people talk about is transparency. There should absolutely be transparency in these arrangements between the PBM and the insurance plan, and then the clients of the insurance plan, right? The employers and so on. And I do think, where there are situations where this arrangement isn't working out, transparency will help to solve that. Know what you're signing up for. But spread pricing has utility, and if you end up banning or restricting a free contractual agreement that includes spread pricing, providing the certainty that many plans actually look for, then that's going to actually end up harming plans and the people that they end up serving.
If you're a new parent, you already know the feeling. Running on maybe 3 hours of sleep, chasing your kid before the coffee kicks in, it's like you're constantly in survival mode. And even if you do find time to eat clean or sneak in a workout, your body's just not operating at full speed. Stress, sleepless nights, and poor nutrition tank your nitric oxide levels, leaving you sluggish, foggy, and unfortunately snapping at the people you love the most. And trust me, I've been there. That's why I started using Cardio Miracle. That's a clean nitric oxide blend that supports energy, circulation, and mood with no caffeine crashes or stimulants. Just ingredients like organic beetroot, CoQ10, and L-arginine that naturally help you stay present, productive, and powered through parenthood. Trust me, this stuff helps you show up for your family. So, scan the little QR code over my shoulder, click the link in the show notes, or simply head to cardiomiracle.com/TBNS to give it a try. And by the way, when you go to cardiomiracle.com/TBNS, you're going to get a discount automatically applied at checkout. Just look for the little note saying you're shopping with Brian Nichols at the Cardio Miracle homepage. One more time, that's cardiomiracle.com/TBNS. And now, let's get back to the show. So what about rebates for PBMs that give this incentive to favor expensive brand name drugs? Because I've heard this quite a bit too. So even when you have the cheaper generic alternative on the market, the PBMs may push pricier drugs that will earn them bigger rebates, but that's going to ultimately hurt the patient, especially those who are paying the list price, right?
I mean, well, the net price, which is ultimately paid, is often radically, almost every case, radically different to whatever the list price is. But I will say that the evidence on PBMs and generic drugs is mixed. In fact, in very many cases, PBMs steer people towards cheaper generic drugs over more expensive ones. Now, if there are specific cases where they're favoring a more expensive drug, again, that comes with costs relative to benefits, right? In some cases, it may not even be a perfect substitute. The non-generic alternative might have a delivery method attached to it, which the generic one doesn't, which makes it more suitable for different kinds of patients. That's one
By
example.
the way, that is a great call out there, because there is this perception that like name brand, generic, they're the same, but in many cases they're actually not. They're like, I've seen this where I've taken like the ibuprofen from Advil and then the Walmart version. I'm like, was that Advil? Are you sure? So is that the reason, because of the delivery methods in some instances?
In some instances, yes. In other instances, look, they might pick the more expensive drug for coverage to get the higher rebate being then passed on to their insurance plans, which means lower premium costs. And I think, a lot of these misconceptions, they partly stem from the lack of transparency to the public, right?
Yeah.
Because these are agreements between private parties, and we don't get to see exactly what goes on behind the scenes.
Well, as I say, by the way, there's been multiple lawsuits, both federal and state, that have accused the PBMs from hiding fees, that steering patients for profit, and then just in general inflating prices. So that definitely leads into the lack of trust because of the lack of transparency in many of these use cases.
Absolutely, and look, I think it's a good thing if you're seeing companies being super specific instances of wrongdoing where evidence gets brought to bear, and we can then have a court verdict. I do know that some major PBMs have settled lawsuits. I mean, they've not admitted wrongdoing, but they've paid out millions of dollars in settlements where they've been accused of anti-competitive practices or not passing on the agreed rebates to the insurance plans. In the state of Illinois, for example.
Isn't that a little bit of a red flag?
Oh, it is absolutely, but that just goes to show you that the law is working as it's intended. What I'm saying is, this is a better approach, right? Targeting specific wrongdoing and having sunlight as a disinfectant, rather than trying to pass laws that say, hey, PBMs, you cannot do spread pricing. You cannot negotiate in this way, because that's going to end up screwing with the ability of markets to compete and deliver the lowest prices to the most people.
So one of the things we were talking about list prices here. So I've seen some folks raise up some studies that show that although the rebate-based drug prices net fell from 2018 to 2021, the non-rebated prices rose too. So like, is that showing a direct correlation to lower total costs across the board? Or is it back to your point where they're able to offer the rebate and then bring that back to other areas?
I mean, look, a number of different things can affect the list price of a drug. And ultimately, who's responsible for setting those list prices? The pharma companies themselves are. So, the pharma companies can't say, oh, look, we're just forced to set these really high prices and charge you guys more because we want to get, on a PBM's formulary. I mean, it takes two parties to make that negotiation.
Takes two to tango is what you're saying.
Absolutely. At the very least, given the large number of factors that affect list price, given the fact that even non-rebated drugs have grown, in their prices, it's clear that, you can't attribute a primary causal inference to the rebates themselves for raising the list prices. It doesn't work out that way.
Gotcha. What about independent PBMs? I've heard this quite a bit. Like all of these PBMs that are out there, there's like 3 or 4 of them that are really like the big guys. And I think, isn't it CVS? They're a pharmaceutical, entity we all know and love, right? They're everybody's, city. They have a CVS or two. But CVS actually buys their drugs from a CVS PBM, which creates this perception of collusion. But then on the other side, if PBMs can't make money from the rebates and markups, it becomes hard for the new and smaller PBMs to enter the market. So it's going to drive even more consolidation. It's going to reduce even more competition. So kind of seems like it's a little bit of a, two sides of the coin there. Is that fair?
Yeah, and look, I think, in any kind of really concentrated industrial market, right, the tendency of people is to say concentration is inherently a bad thing. We have to do whatever we can so there's less concentration, and this will then lead to better outcomes. Not necessarily the case. Often concentration is a reflection of the fact that either A, only the biggest and most consolidated firms can do really well or have a unique advantage because they have scale economies in delivering the best deal possible. Or it's a reflection that, this is just the natural state of how this industry is going to operate. One of the points I do want to make about, look, and there's 3 big PBMs, CVS, Caremark, Express Scripts, Optum Rx. They corner about 80% of US drug prescriptions, right? So the idea that these 3 would be scrutinized heavily, I think, is a fair point. With that being said, a lot of, even insurance plans that aren't a part of the PBM conglomerate are incentivized to hire, in many cases, these PBMs so they can be a part of that bulk buying power as well. So they clearly see some value in it. And independent PBMs exist too. They offer the fee-for-service model, for example, which is not based on the volume of the rebates. There are many different options available. A concentration doesn't mean these options don't exist, and many plans do opt for them. But that's exactly what we want. We want many different options available, and then plans can choose what works for them. And if there is a situation where a firm is accused of anti-competitive conduct because it is using its market power to degrade price or quality, that's illegal under the antitrust laws, and those investigations can go on, those lawsuits can be brought. But there just is not a case for new legislation, which would prevent things like you mentioned, the steering, right? What steering does, steering your insurance customers to your, let's say, the pharmacy chain, in the case of CVS, that creates huge customer volumes, which leads to more bulk buying power and lower prices for those customers. And what's interesting is there's been a lot of talk about, rural pharmacies are closing down because these PBMs are so powerful with their buying power and they're able to charge such low prices that these pharmacies can't operate. We need to do something, prevent these PBMs from steering people to their chosen pharmacies. A number of rural localities, the closest pharmacy is one that's part of the conglomerate. It might be a CVS, for example. It might be a Walgreens. So you're not actually helping out those patients. In many cases, these rural pharmacies are suffering because of population decline, because many people living in these areas opt for mail order delivery. So we should always look and see what the facts are on the ground before we jump to conclusions that are anti-competitive.
Do me this. Steelman their argument, though, for the mom and pop pharmacies, right? Because I live out here in a little rural town in Indiana, and you mentioned 2 of everybody's favorite pharmacies, right? CVS and Walgreens. I got those. One's over there and one's over there. I could actually probably throw a football and hit each store. But then I got another one over there. I could probably throw a football and hit that one. That's Fred's. Fred's got his pharmacy. And I guess like to the Fred's pharmacies that are out there, like he's got very real competition from these 2 ginormous, conglomerates that are out there. If I was Fred, I definitely would feel, I don't want to say attacked, but like when you see that CVS and Walgreens are able to just buy in bulk and get so much more. I mean, Fred represents more than just Fred's pharmacy, right? Like Fred is Fred. We know Fred. Fred goes to the Memorial Day parade and has a float. Fred is at the different, the football games. Like Fred is a part of the community. And I think there's this other argument being made, and it's much more populist in nature, of saying, well, listen, I get it. Like we're trying to walk and chew gum at the same time here. We want lower drug prices. We want these PBMs to help incentivize lower drug prices. We have multiple pharmacies now, so we're creating competition. But it's like David versus Goliath with Fred versus Walgreens or CVS. So to that, like if Fred's were to close, there would be much more of a negative impact from not just now we have only 2 options as a pharmacy here in the community, but now we're losing Fred's ability, like as a human being, to produce in his community because he's now being pushed out by these large faceless entities that just kind of moved in and were able to in many people's minds, control both the outcomes of the game, but also the inputs to the game. So is there any merit to that way of thinking or in that way of argument?
I mean, it depends on what you price and value, right? I mean, we saw similar arguments made when Walmart moved in, leading to the closure of a lot of mom and pop stores. But what does Walmart do? Walmart gives us low prices. People are happy to go and shop at Walmart and get what they need for a lower price. And what's interesting is the communities where you find the most boutique, independent mom and pop stores are affluent communities where people are prepared to pay a premium to have a boutique experience. And I would say, it's completely understandable that someone would want their community to have a certain amenity or look a certain way. I can understand the feeling of, well, we used to have all these small business people and now they have to work as employees when they could have previously been independent. I can totally sympathize with that. But look, if we're going to favor those people and their fair perspective, that's fine. But it comes at the expense of other people. It comes at the expense of higher prices and less access to, in this case, medicine. And one thing I'd also like to point out is, independent pharmacies actually are not, as a class of pharmacy, really suffering. In fact, independent stores have grown at a greater rate in many places where even the chain stores have shut down, going back 10 years or so. There's a recent study on this. And what these independent pharmacies typically do, especially if they're in areas where they're getting business, is they form their own, bulk buying associations called PSAOs, Pharmacy Services Administrative Organizations, right? So they kind of do a similar thing to what the PBMs do, but on their own behalf, and they're able to go toe to toe with these, large chains. But that being said, among rural pharmacies, it's a different story. Why? Because of population decline, and that's ultimately not anyone's fault. It's just the way things play out. And I would say, look, for the people who are seeing, the only pharmacy that they have access to being an independent one in some very low population remote community and it's closing down, I can understand that. And I think the best thing you can do in that situation to make sure that you don't end up harming other people is a targeted welfare response. So provide a cash supplement or some kind of subsidy for people who genuinely cannot afford the medication they need, which in turn leads to them not being able to buy at the local pharmacy. That would certainly work out better than saying, well, we're going to harm the majority of people who go to, let's say, a chain store, just so the rural store that serves few people can survive.
No, interesting. There's two more objections I wanted to get through here today. One of them, rebates mess with patients' out-of-pocket costs. I heard this a lot from folks. Since copays are based on the list price, not the discounted price, high rebates lead to high upfront costs, hurting sick patients with big bills. What say you?
I mean, that might be true in a specific instance, but again, keep in mind, right, if something has to go up at one end, it might have to come down at another end. And the question is, what do you value more? Do you value lower premiums for everyone more, or do you value specific patients having lower prices at the end of the day, right? And you might say, well, it is really horrible for, let's say, a segment of a few hundred people who have to pay a higher price for a drug. I sympathize with that. In return, maybe 1,000 people end up paying less for other drugs or end up paying less for the cost of the coverage themselves. So, we need to make these trade-offs. We need to be honest and say, I'm willing to sacrifice at point A so I can, support the people at point B. And I would say, I mean, look, I'm going to do the cliche thing and say, let the market decide, right? But if we're going to intrude in that and say, okay, this is unfair, we have to prevent it, we should at least be willing to say, at the expense of who?
If you're a business owner, do you ever open your phone bill and feel like you need a decoder ring? Regulatory recovery fee, support access surcharges, platform licensing. Half the stuff on there is just made up jargon for we felt like charging you more, and here it is. And don't worry, other folks are over it too. And that's why I am recommending you Level 365. They're upfront, no hidden fees, no surprise line items, no games. You pay what you agreed to. Period. And if you need help, a real human answers the phone. Clean pricing, real support. It shouldn't be revolutionary, but here we are. Yep. Understood. Last question I had for objections. So this one's actually, it's an interesting approach I got for this objection. It was that the system is hiding the real cost of innovation because pharma often spends more on marketing and buybacks than they do on actual research. So the rebates let prices rise unchecked, meaning that patients subsidize these quote unquote blockbuster tactics instead of real research and development. Thoughts?
I don't think there's really much evidence for that. I mean, we know that the costs of getting a drug through FDA approval, the many, and as well as the billions of dollars in failed trials that don't yield a commercially valuable drug. And then when you even get something you can patent, it might not be commercially valuable. So there are huge upfront costs when it comes to pharmaceutical research. And some studies, in fact, find that in many cases, the social value of a new drug, because after about 20 years it goes generic, the social value of new drugs to society is not fully internalized even by the high prices that we pay just because of how expensive it is. And if you want to talk about something that's inflated drug prices in the US, beyond what would be the cost of recouping the innovation and so on, it is the way that CMS, Medicare, Medicaid actually decide what price they pay for drugs in many cases. In many cases, it is rather than negotiating drug prices the way other countries do, the price is pegged to the average or the lowest price the private market pays. But keep in mind, CMS buys more drugs than anybody else in the US market, right? So what does the pharma company do? The pharma company says, well, we could sell at a much higher price to these insurance plans, and the insurance plans will, if it's above the market price, they'll buy fewer drugs. And normally we'd lose money, but the thing is that high price per drug, we're going to get that for every drug that CMS buys, right? So there's been research showing that this leads to an inflation of the price. Meanwhile, other countries essentially free ride off this US innovation. So Americans, both in the public and the private market, pay 3 to 4 times more for the drugs what people in Sweden or Norway end up paying.
Which, by the way, that sounds like more of a big issue that we should talk about. Like, why is it that we are more or less subsidizing the healthcare costs of these not third world countries? Like, they are first world countries. You mentioned a few of them, but like, I hear that and I just instantly have a knee-jerk reaction like, sorry, no, I don't want to do that anymore.
Oh yeah, absolutely. And it's funny, I'm from Australia originally, and realizing how expensive things are in the US got me thinking, like, this is kind of crazy. Why is this the way it is? And keep in mind, the pharma companies, they're fine with the status quo because whether they get their money from the US market or the foreign market, either way, right, it works out okay for them. But then in an ideal world, we'd be paying roughly similar prices, right, for the same drug. Those countries will be paying more to fund the innovation they're benefiting from. And Americans, taxpayers and private plans alike, will be paying at least something comparable to what they're paying. And there are ways of doing this. I've written about this as well. The Trump administration talked about something called most favored nation pricing, where they would just peg the price that CMS pays to the price paid by a basket of foreign developed countries. And this would, in theory, force the pharma companies to charge a higher price to those public insurers so they can raise the US price. It would also remove the incentive to overcharge private health plans in the US, which is a good thing. The only problem is you would probably have a race to the bottom because it's unclear that those other countries will simply say, okay, we're going to pay a lot more for these drugs now. They may not have the political will to do that. So the trade-off of that approach would be, well, probably less money for future research and development. So I think what we really need is maybe something like that paired with a global, a way that governments can come together and agree on some kind of reference price that the public insurers will all pay, taking into account the value not only of trying to have a low price, but also the innovation, the R&D that went into getting that drug out in the first place.
Interesting. So we got like 5-10 minutes or so left here of the show. I want to have you, the best you can, steelman the position of the skeptics, right? Like the person living in my rural community who's like, I don't know, Satya, that doesn't sound like it's a good thing regardless. Like, I don't want Walgreens and CVS coming in here, or I'm afraid that we're going to be paying more unintended prices because of the lack of X, Y, and Z. Like there are a lot of these issues that people are still going to be focusing on, like, oh, these PBMs are marking up the specialty generics. Oh, these PBMs are their spread pricing's hiding more of the costs, right? So what would you say from a steel manning their position? Like, what's the best argument against PBMs? And then the next part I want you to do is give us the actual outcome that you would see tangibly exist if that skeptic got their way? What would, and obviously from your perspective, it's gonna be a negative outcome, but like, what would that world look like?
All right, so if I had to absolutely steelman their perspective, I would say, look, we have a highly concentrated market where three major firms end up getting 80% of the prescriptions. We know that their commissions are tied to the rebates that are negotiated. So even if list prices have gone up for a number of different reasons, maybe the rebate has some effect on it, and maybe we should look more closely into this. Maybe we're in a situation where, because there are so few players in the market, or at least so few large players, insurance plans outside of the conglomerate are kind of forced to hire the largest PBM possible because they feel that's the way to get the lowest price possible. But then this kind of market power means that the PBM can engage in doing just enough that they can retain their clients, but they're not actually negotiating the lowest prices or the best deal possible. They might be pocketing more that they have to pocket in a market that ideally has more competition in it, where they face more challenges for other players. And we may not know the exact answer in every single case, but it's simply too difficult to get the FTC or the DOJ to investigate all of these companies all of the time. That costs taxpayers money to do all of that. Wouldn't it be simpler if we just had more players in the space, keeping a check on each other, on their prices going up or down? And also, I live in a small rural community. My best friend runs his own business. It was his dream. He put a lot of his money into setting up that pharmacy down the road. He knows everybody. If Bob, who's turning 90, can't afford to buy his prescription for that particular day, he says, Bob, let me give you a line of credit. I'm not even going to write it down. This one's on me. Pay me back when you can. CVS or Walgreens comes in. They don't care about that. They just say, oh, you have a problem? Call corporate. So, maybe we should be thinking about Bob first and Frank first, because these are the people who keep our community going and alive, whoever's still left over here. Maybe that matters more than this idea of squiggly lines on price going up or down. That's my attempt at a steelman. What would the result of all this be? Well, it would be a higher prices and less competition across the board for the vast majority of people. It might well mean that Bob and Frank are better off, and that's a great thing. Nothing wrong with that. But at whose expense? And that's often something we don't get to see until this idealized utopian world we've been promised comes to being. And as we know, often, it isn't quite what we imagined it would be in the first place.
Yeah, the path to hell is paved with the best of intentions, Satya, for sure. I really appreciate this conversation because, frankly, this is an area that I'm just not super well versed in. Healthcare policy, it gets dense. PBMs and CSMs and FTC. We're going through all these acronyms today. It was like buzzword bingo. But I think for your average person listening, like the reason that so many folks are invested in having some type of alternative solution presented is because I think we've really seen, especially in a post-COVID era, where the trust towards these big pharmaceutical companies is at an all-time low. And I think it's rightfully deserved in many instances where, COVID, it was the COVID vaccine that ended up, did it save us from ourselves or was it, something that ended up causing a lot more pain and suffering? And you see the behind the scenes stuff there from, not only on our government official side, the CDC, the NIH, the FDA, all basically like walking in lockstep during COVID, being like, of course, Big Pharma, you can do no wrong. Every CNN commercial before it starts is brought to you by Pfizer, right? Like that is what folks over the past 5 years have really been just inundated with time in and time out. So I think there is very much I don't want to say an allergic reaction, but just kind of this skepticism that's starting to drip more into like just outright not enjoying these big pharma companies. And then you couple that with, I forget that Netflix show, but it was with Amanda Seyfried that was making the whole Elizabeth Smart, she did her whole pharma thing. I forget the use case for the drug is like something about it could, I think, see cancer in your blood. I forget, but
it was a testing product.
Yeah, that's right. But like that came out during COVID, right? So people are, watching as they're being told that this vaccine is going to save their lives. And they're like, well, where have we heard that before, right? So I think across the board, this skepticism towards Big Pharma has really created a negative sentiment towards Big Pharma in general. And like, listen, I think there's a lot of folks more in like the Make America Healthy camp. They're more focused on, well, listen, these pharmaceuticals, they serve a role to help deal with issues after they become issues. Let's talk about making sure that things don't become issues at the onset, right? Let's talk about living healthy, eating right, having a cleaner environment. Like, these things are all inputs into our output of health. And if we're not taking those in consideration, then yeah, we're going to have to rely more on the big pharma stuff. So then that goes into more of the skepticism and almost conspiracy mind around, well, if big pharma knows that they need to keep us, basically as loyal customers, that seems like an incentive to me. Does that check out, right? And that's where I think a lot of folks enter this conversation today. So Satya, I really appreciate you coming on the show. Give us your final thoughts for today. Wrap us up in a nice, neat bow.
Yeah, sure. Look, this is a complicated space. You have pharma companies, you have PBMs, you have pharmacies, and there are often bad actors among all three of these groups. And sunlight is the best disinfectant. More competition is actually the best disinfectant. And the more options that people have to be able to choose something that works for them, whether it's a big conglomerate or whether it's an independent PBM with a different model, the better things are. And, pharma is overall, like, you may not like the industry, you may not like the companies, but they do something amazing and amazingly valuable. What they produce does end up saving millions and millions of lives. And, in our rush to go after these companies, and we should if they've engaged in wrongdoing, let's just also make sure that we can still have a competitive ecosystem where new cures are being discovered and they're doing what we're paying them to do.
Satya, where can folks go ahead and follow you if they want to learn more, and obviously check out some of the work that you're promoting there? I know we had your article here today over at Counterpunch. I just lost the article. I'll go ahead and share that on screen. So yeah, tell us where that is, and I'll go ahead and get that shared.
Yeah, sure. So I do have a Twitter or an X, Satya Marar, and I can link that. But also we have a Substack. We have a newsletter at the Competition Project at the Mercatus Center that I put together. It goes out twice a month on issues in competition, whether it's drug prices or artificial intelligence or anything else. And it's a quick digest. It keeps you in the know. You will find insights you won't find elsewhere. So follow us at competitioncorner.substack.com.
There you go, folks. All right. Well, if you got some value from today's episode, please go ahead and give it a share when you do tag yours truly at B Nichols Liberty on X, on Facebook, and Instagram. Subscribe to the show wherever it is you watch your favorite podcasts or your videos, YouTube, Rumble, Apple Podcasts, Spotify, the whole rigmarole. You can go ahead and find The Brian Nichols Show. With that being said, we're going to go ahead and put a pin in today's conversation. Brian Nichols signing off here on The Brian Nichols Show for Satya Marar. We'll see you next time.
Thanks for listening to The Brian Nichols Show. Find more episodes at briannicholsshow.com.